Hello everyone. Today we'll be talking about cardiac allograft vasculopathy. The development of coronary artery vasculopathy is a well-known limitation of cardiac transplantation. So frequently in patients who underwent cardiac transplantation, this is a common abnormality which keeps occurring and which is called as coronary artery vasculopathy is an immune-mediated reaction which occurs, which is different from the actual coronary artery disease. It is frequently seen in both younger and older recipients, and its prevalence increases with older donor age. If the age of the donor is increasing, the frequency of this coronary artery vasculopathy also increases. So its annual incidence rate is around 5 to 10%. Coronary artery vasculopathy is detected angiographically in up to 20% of transplant hearts at 1 year, and in 40 to 50% at 5 years. So around 5 years time, around 40 to 50% of patients of heart transplant develop this vasculopathy. This is basically seen because of immune-mediated phenomena with myointimal proliferative lesions characterized by intense cellular infiltration. So it causes intense cellular infiltration and myointimal proliferative lesions. So when comparing it with the coronary artery disease, it can affect all vessel types within the allograft, mostly intramyocardial vessels. However, coronary artery disease generally affects the proximal coronary vessels, whereas this generally affects the intramyocardial and distal and mid part of the coronary vessels. And the plaque pattern is generally diffuse and concentric, whereas coronary artery disease generally it is focal and it is eccentric. Inflammation is definitely present and it is rarely seen in coronary artery disease. An internal elastic lamina is generally intact. Here in coronary artery disease, it is disrupted. And calcium deposition is seen in coronary artery disease because it develops a slow process and there is calcium deposition as well. So this is the difference between the cardiac allograft vasculopathy and coronary artery disease. So you can see here, this is a concentric allograft vasculopathy you see because of the intimal thickening, as well as you can see here the thickening of that. Here it is eccentric and plaque buildup, which is seen in case of normal coronary artery disease. So coronary artery vasculopathy angiographically is graded by the International Society of Heart and Lung Transplantation, and it generally characterized by diffuse disease, and there is distal obliteration or pruning of the coronary arteries. So you can see here there is distal obliteration and pruning. You can see peripheral pruning is seen. The decrease in diameter of the scale. So there is diffuse disease with the peripheral pruning. You can see here in the distal vessels of it, suggestive of coronary artery vasculopathy. So by the grading wise, it is by the International Society of Heart and Lung Transplantation. It is divided into four classifications: CAV 0, 1, 2, and 3. So CAV 0 means that there is no detectable angiographic lesion, that is normal. There is CAV 1, there is mild, which is defined as left main disease if it is less than 50%, or primary vessel with maximal lesion of less than 70%, or any branch stenosis less than 70%, without allograft dysfunction is called as is graded as CAV1 type. So CAV2 is nothing but there is moderate. That means the angiographic left main disease is generally less than 50%, but a primary vessel diameter of stenosis is of either 70% or isolated branch stenosis, any branch stenosis of more than 70% in two systems. That means there is two vessels should be involved with more than 70% of stenosis and without allograft dysfunction. There is no allograft dysfunction, you can say. So CAV3 is nothing but is angiographic left main disease of more than 50%, or two or more primary vessels of more than 70% stenosis, or isolated branch stenosis of more than 70% in all the three systems. It should be present in all the three vessels and two or more primary vessels with more than 70% stenosis. So what do you mean by allograft dysfunction is that allograft dysfunction means if the ejection fraction is less than 45% in the presence of regional wall motion abnormality is called as the allograft dysfunction. So the primary vessel is nothing but is denoted as any vessel which is involving the proximal and middle one third of the artery, coronary artery is called primary, and secondary branch is something which is distal 33% of the primary vessel or any segment or with any branches, that is diagonals or obtuse marginal arteries. So how do you treat a case of coronary artery vasculopathy? It is seen that there is evidence that statin therapy improves outcomes for heart transplant recipients. So irrespective of the lipid levels, you should start statins in all the patients of heart transplantation. Low-dose aspirin is also recommended by isolated reports demonstrating improved survival with the aspirin use. So aspirin use also has been found to be beneficial. Ultimately, the only treatment for extensive coronary artery vasculopathy is retransplantation. However, retransplantation is not an easy process. As we all know, there is lack of donor hearts which is there. So retransplantation is not an easy, but the ultimate treatment for coronary artery vasculopathy, if it is very severe or extensive, is the retransplantation. There is an option of using mTOR inhibitors like everolimus, sirolimus as a part of immunosuppressive regimen because it is an immune-mediated disease. So if you suppress immunosuppressive drug, if you use like an mTOR inhibitor, it was found to have some role in coronary artery vasculopathy. So although yearly coronary angiography was the initial standard followed by the use of IVUS in conjunction with angiography, more centers are now using various non-invasive testing protocols are being used to detect this coronary artery vasculopathies. Thank you.